Hi everyone, welcome to the Paramedics Zoom to Final session. My name is Owain, I'm one of the final years based at Chester, and this is on the respiratory pathology. So just a little bit about what's going to be covered today. So I've been asked to do lung cancer, asbestosis, and pleural effusions. And I'm just basically going to go into what I think is the most important topics and what is most likely to come up in examinations. So what I've also done is the slides are a bit sort of text heavy, but basically what I've done here is I've just covered, I think, everything that you need to know. I think anything beyond this is irrelevant to what will appear on your finals. So just use this as a resource in the future, hopefully. And, you know, if you've got any questions, just, I know I've done enough of these Zoom sessions myself, just message me and I'll make sure I read the questions that come in. So first we'll go on to lung cancer. So lung cancer is quite a sort of a large topic, and it's very easy to get sort of swept up in a lot of the detail. So I'm just going to try and keep this as simple as possible. So basically there are 5 types of lung cancer. I think it's only really 2 that I'd say you need to know in reasonably good detail. So in terms of the causes of it, as we all know, sort of smoking is a very high risk factor for that, and it sort of constitutes about 90% of case causes. But we also have other causes such as asbestos, and sort of urban pollution, mining, and you know, I think everyone knows this quite well. So just talking a little bit about how this would present. So actually, it's very varied. So you think of some of the really like sort of classic symptoms such as hemoptysis, breathlessness, chest pain, wheeze, things like that. They're not present in all patients, and actually quite a few present with sort of just through a routine chest X-ray where you see a lesion on the screen. So some of the other ways that it might present is you might have sort of chest infections that just keep coming and coming and never really get resolved. That can tend to be quite a bad sign, particularly in a patient who's got a very strong history. And then you need to consider all the other symptoms that you tend to get in any sort of cancer, such as like anorexia, weight loss. And then you've also got a few other sort of signs that you might get very specifically in lung cancer, such as Horner syndrome, dysphagia, and pleural effusions, but I'll get into that in a bit more detail. So just a little bit about the signs as well. So we talk about sort of the systemic signs, the chest signs, and also like metastatic signs as well. So systemic signs, I think we should all, this is stuff that I feel like you really do need to be quite very familiar with. So sort of if a patient looks very cachectic, if they're anemic, if they've got finger clubbing and sort of weight loss as well, that is sort of very characteristic of any sort of cancer. If you sort of double that up with anything that's more sort of strongly indicative of lung cancer as well, that would point you towards the the diagnosis. Just talking about chest signs as well, it is, I have seen it in on the ward myself, where you see like patients with these inspiratory like wheezes and stridors, and that's basically due to the tumor sort of impacting on the bronchi and the bronchioles and sort of changing the frequency that the air is able to come in and out. You'll also have like sort of consolidations as well. So if you diagnose it clinically through a similar sort of way as sort of any pneumonia, things like that. And then as well, sort of lung cancer has a definite propensity to metastasize. So if you're looking for sort of bone tenderness, hepatomegaly, maybe sort of seizures, anything that might indicate brain pathology, anything else like that, that would be a sign that the disease is already metastasized. So just talking a little bit about the lung cancer sort of subtypes, I think it's really easy to get sort of swept up in excessive details. So I think just keep it very simple. So I'm going to mention sort of 3 in reasonably strong detail. So first off, we'll just talk about is squamous cell carcinoma, and this is the most common. It tends to occur in sort of the main bronchi, and it's very strongly associated with smoking. It is quite malignant compared to other subtypes of lung cancer, and I'd say that's really all you need to know about it. Talking about adenocarcinoma as well, that's something you should just be sort of peripherally aware of. So this is less associated with smoking, but there's still that association, and it's also found more commonly peripherally. So you might find that it's more likely to resect. So you'll find it sort of in individual lobes. and it's also considered the least malignant out of the main lung cancer types. I've mentioned here sort of carcinoid and alveolar carcinoma. I think just be aware of it. I'd leave that to the respiratory consultants to think more about. And I just want to talk a little bit about small cell lung cancer. This is one that is quite common, and it tends to give you sort of a constellation of quite unusual symptoms. So it is a neuroendocrine tumor, and it arises from sort of lung-specific immune cells. And the reason that this is quite unusual is because it has this ability to secrete different hormones. And I'm just going to talk about a few of them and some of the syndromes that you get associated with small cell lung cancer. It is worth just pointing out as well that it's got a very terrible prognosis. It metastasizes very quickly, and most of the presentations of small cell lung cancer have already metastasized. So just talking a little bit about paraneoplastic syndromes, which is what is sort of associated with small cell lung cancer. The first one I'm going to talk about is the syndrome of inappropriate antidiuretic hormone, and that is the most common of the paraneoplastic syndromes with small cell lung cancer. So this tends to be sort of excess antidiuretic hormone secretion. So what you'll get is sort of fluid retention and hyponatremia. Basically, this is because you've got a normal level of hyponatremia, but there's more fluid in circulation, so it gets diluted out. You'll also find that the urine is also quite concentrated as well, as you're not sort of passing as much fluid in your urine. So if you see a patient who's got sort of deranged electrolytes, and they've also got this malignant picture. I have seen a question quite similar to this come up, but it's just to be aware of. You also have other ones like beta HCG secretion, so this will give sort of gynecomastia in males. You can also have sort of ACTH secretion that will give you a very Cushingoid picture. And then you've also got sort of one that's just quite popular on the textbooks, but never really comes up anywhere, which is Lambert-Eaton syndrome. So you sort of get this sort of muscle fatigue picture where you get muscle weakness and various things like that. So just to be aware of, don't read too much into that. So in the lecture that we had on lung cancer, we were given this slide, and I think it was really, really good. Basically, depending on where the lung cancer occurs, it gives you a very different clinical picture. So as you see here, if you have sort of tumors that appear up in sort of the upper right lobe of the lung, you can get a picture of a Horner syndrome, and this is where it's basically impaction on the sympathetic nerves, and this gives you a very specific facial syndrome where you get sort of anhidrosis, ptosis, and sort of constriction of the pupil as well. You also have other things like recurrent left nerve palsies. So this will give you a very hoarse throat, hoarse voice, sorry. And then you get other things like SVC obstruction, which is where you sort of get pooling of the venous return from the sort of the upper part of your body, so basically the head and the arms. And this gives you, I'm not sure if you guys have all covered palliative care yet, but this is a big topic. And it's one of the oncological emergencies, so definitely be aware of that. And in addition to that, it also causes pleural effusions, which we'll cover later on in the presentation. So I found this slide as well. I think this is really just sort of the cornerstones of what Horner syndrome looks like. So you basically just get this loss of sweating on only one side of the face, a partial drooping on only one side as well, and then a meiosis as well. So investigations, generally speaking, it's sort of done for two purposes, and that's number one for diagnosis, but also very importantly, number two for staging as well. So probably the most important one that you can do for diagnosis is a CT scan. So if you are, it obviously depends where the patient presents. If you're if you're in GP or you're in sort of primary care, you'd want to refer to sort of the 2-week pathway if you're suspicious of the lung cancer. But when they get there, they'll be getting things like bronchoscopies, CT scans. They get what's known as an EBUS. I'm not sure if many people are aware of exactly what that is, but basically it's very similar to a bronchoscopy, but it's sort of a bit of a bigger scope, and it has a sort of ultrasound tip at the end of it, and that allows you to sort of take biopsies under guidance, and it's considered sort of the gold standard in terms of sort of a bronchial approach. Talked a little bit about sort of cytology, fine needle aspiration. So when you're looking at cytology, this just looks at sort of individual cells. It's not quite as accurate because when you're looking at cancer, you want to see how these malignant cells interact with normal tissue. So you might want to do something more like a fine needle aspiration, or like a proper biopsy, and it'll give you a nice sort of contrast between normal tissue and malignant tissue. PET scan as well, that will give you a good indication of whether it's a metastatic disease or not. And I mentioned in here spirometry as well. So for one of the subtypes of cancer, which is the adenocarcinoma, it is quite common for these patients to be referred for lobal resection. But as you can imagine, the patients who typically get lung cancer are those who have smoked sort of 40 a day all their life, and their respiratory reserve is not always the best. So if you do a lobotomy, you might reduce their capacity for oxygen transfer, so much so that they might go into respiratory failure entirely, which would be sort of contraindicated for any surgical intervention of lung cancer. So just something that might actually come up in your exams, which is quite common. This is what sort of lung cancer tends to look like on a chest X-ray. So there are several ways that it might appear. So you'll get sort of peripheral nodules. You can get hilar enlargement, and that's sort of just engorgement of the large pulmonary arteries. You can also get sort of consolidations around the tumor, and that's because of sort of the inflammation and the fluid that collects around it. You can get pleural effusions. You can also get sort of metastases to the ribs. So it's always worth checking sort of the bony structures as well. It's one of the few things people very frequently forget when they're doing chest X-ray interpretation. And finally, one of the things that is sort of most indicative is a coin lesion, coin-shaped lesion. And I've included here a nice little mnemonic for sort of what to think of when you see a coin lesion. And as you can see, most of the causes are actually quite rare. So foreign body is reasonably common, but you'd obviously find that more in children. So when you see a coin lesion in an older person who is sort of giving a positive history for lung cancer, it's very indicative of lung cancer. So just a little bit on management. You've got your sort of chemotherapy, you've got your radiotherapy, you've got your immunotherapy more recently, and you've got your surgery as well. But generally, very frequently, you will be needing palliative care sort of input for this. As with sort of all cancers, you tend to leave the main management, the definitive management, to the sort of medical oncologists and the clinical oncologists, and the consultants sort of manage that. So I really wouldn't worry too much about really the drugs they use or anything like that. What is worth learning though is sort of the fallout that you tend to get from lung cancer, and that is sort of the typical sort of oncological emergencies, which should be covered in more detail in your paramedics palliative care lectures. So I'll very briefly mention sort of things that you might be sort of dealing with, which would be the metastatic spinal cord compression. You can get sort of hypercalcemia from this. You can get SVC, obstruction. Other things like neutropenic sepsis, which is more for when you've when the patient's already received chemotherapy. And you can also get sort of tumor lysis syndrome, which is where you get increased potassium released due to the cell rupture. and that gives you, a risk of sort of cardiac arrest, things like that. In addition, you'll be dealing with sort of the symptomatic management. So you'll be doing, things like oxygen supplementary prescribing, pain management, things like that. So that's the sort of thing that I would learn quite sort of strongly in regards to lung cancer. I've not included anything about sort of 2-week waits. I think you just need to have to learn that, to be honest. So be very familiar with 2-week wait criteria for all sort of cancers. And that is stuff that very frequently comes up, and I would learn that sort of inside out. But if in doubt, 2-week wait. If you think it sounds somewhat suspicious, it's always better just to be sure. So I'm going to move on to the next heading. If anyone's got any questions so far, you can just type it in if you'd like, if you'd prefer that. No? Okay. So next I'm going to move on to pleural effusions. So I think pleural effusions tend to get quite sort of a mix up with pulmonary edema. So I'm just going to very clearly sort of differentiate the difference between the two. And, I think this is real sort of exam fodder. So definitely just have a good understanding of this before your finals. So just a quick definition. So it's basically a buildup of fluid between the pleura, which is the membranes sort of between the lungs and the chest wall. There are a number of different causes for this, and you'll find some people sort of mix into this, not just sort of pleural effusions, but also empyemas, pneumothoraxes, hemothoraxes, chylothoraxes as well, which is buildup of the lymphatic fluid. I'm not going to go too much into detail on that. So just giving you a quick sort of touch up on pulmonary edema. So pulmonary edema is basically where there's excess fluid in the lungs and in the alveoli, which makes it very difficult to sort of breathe, and you'll get much sort of stronger symptoms of shortness of breath, things like that. Pulmonary edema is basically always cardiac related, whereas pleural effusions are less so. So that's how I sort of remember it. You can also get sort of more unusual causes of pulmonary edema, but as you can see sort of on the other causes, it's pretty rare apart from PEs, but I would just basically think of pulmonary edema and cardiac failure. So I'm just going to show a chest x-ray showing the difference between the two. So for your pulmonary edema, you basically want to look for your A, B, C, D, E criteria. So I'll not go into that because I think you've already had lectures on that before. But definitely know your A, B, C, D, E for pulmonary edema. Whereas when you look at pleural effusion, although they can be quite similar, you'll find that pleural effusions, if it's unilateral, it's pleural effusion. If you can very strongly see a meniscus, so along here, I don't know if you can see my mouse. I don't know if you can see my mouse here, but there's a meniscus here that is much more indicative of pleural effusion. You'll find also sometimes this can cause a deviation of the trachea as well. So and that will sort of push it to the contralateral side, whereas pulmonary edema will not do that. You can also get mediastinal sinus shift, and I think the X-ray I'm showing here does have a bit of that. So just helping you sort of tell the difference between the two, and this would be very useful for your sort of management and your investigations. So basically there are sort of two main distinctions of pleural effusion and what causes them. So you've got your transudative causes and your exudative causes. So basically the pleural fluid volume is maintained by sort of quite a complicated balance of sort of hydrostatic forces, oncotic pressure, and the integrity of the capillary membranes as well. And basically any disturbance of this can cause a pleural effusion. So I'll talk a little bit about transudative causes first. When you hear transudative, think of sort of fluid overload and your sort of inability to control where fluid should be. So think of cardiac failure. I know I did say before that pleural effusions, cardiac failure causes pulmonary edema more so, but it can be sometimes cardiac related as well. So it can also be fluid overload as well. Any sort of thing that would cause a lack of albumin, so liver cirrhosis, nephrotic syndrome, that will cause a transudative pleural effusion. Moving on to exudative causes. So this is really anything that has any inflammation associated with it. So, think of your infection, think of your malignancy. Asbestosis as well can cause an exudative pleural effusion. And really just the causes are very wide as well. You can even have like pneumonias, arthritis, like rheumatoid arthritis. Any sort of rheumatoid condition could cause an exudative pleural effusion in certain circumstances. So I think that's kind of all you need to know about that. So in terms of how you diagnose it, the symptoms, it's basically asymptomatic if it's small enough. So basically most people would say if it's less than 300 milliliters volume, it's going to be asymptomatic, and you'd only really find this through a chest x-ray. Some people will say less than 200 milliliters, but it sort of depends on obviously how big the patient is. Otherwise, you'll find sort of symptoms of shortness of breath and other classic sort of respiratory symptoms. So shortness of breath, pleuritic chest pain, things like that. And I think just anything that would be indicative of respiratory symptoms, just consider pleural effusions at the back of your mind. So just a little bit about signs as well. So this is, I would say, quite similar to sort of any sort of consolidation. So you have decreased expansion, you have stony dull percussion because it's fluid and not sort of the air or the normal tissue. As it's also sort of fluid based, you'll have decreased breath sounds as well, because obviously not as good sort of gas exchange around there. And you might also find tracheal deviation away from the effusion. So investigations, there's not really a whole lot that's very specific in terms of how you diagnose it. Generally, chest x-ray is the way you'd want to go. Another one that you definitely need to know about is diagnostic aspiration. I've given you a little bit about the instructions of how to do that. I wouldn't worry too much. Basically, the reason that you'd want to do the diagnostic aspiration is because you want to be able to tell the difference between an exudative cause and a transudative cause, because basically, depending on which one it is, very much influences your management and how you sort of approach the patient in general. So the most important aspect of the diagnostic aspiration is the protein concentration, but you can also have a number of different tests you'd want to send to the lab, such as glucose, pH, LDH, lactate dehydrogenase, as well as sort of like bacteriology and cytology as well, if you're concerned about cancer. Basically, if it's less than 25 grams of protein per liter in the pleural fluid, it's transudative, and if it's more than 35 grams, it's exudative. So, an easy way to remember this is that you only get transudative pleural effusions because there's not enough protein in the first place. So it wouldn't make sense you'd have high protein in the pleural fluid. And with exudative causes, it's because the capillaries are very leaky, and you're basically just opening up whatever content of the blood, whatever the content of the serum is, it basically leaks out into the pleura, so you'll get very high albumin levels. So in between sort of 25 and 35 grams, you'd apply the light criteria, and this helps you sort of distinguish what the cause is more specifically. So with this, you'd want to use your protein, which you should already have known, but then you'd also want to look at your lactate dehydrogenase as well. So you would basically, I'm not going to read it out for you, but it's definitely worth being aware of this. And in terms of the protein and the ratio between the two, so the pleural protein versus the serum protein, so you'd also want to do a blood test as well to get an idea of the albumin levels. So if there's low levels of protein in the pleura compared to the serum, you'll know it's transudative, and if it's high, it's obviously more similar to the components of the blood, so it's going to be exudative because it's leaking so much. So I'd say that's kind of all you need to know about sort of pleural effusions. I've not gone into too much detail about empyemas and chylothoraxes and hemothoraxes. Basically, the only thing I would say that's important about an empyema is that when you draw the pleural fluid out, you'll find that it's much more straw-like, yellowy, sort of nasty, gunky-looking stuff, and it'll be full of cells like neutrophils and bacteria, things like that. Whereas if you've just got a run-of-the-mill transudative or exudative cause, that's going to be because of it'll give you just like a nice sort of gin clear fluid, as they describe it in the textbooks. So management, generally, obviously it depends on the cause, but if they're obviously low in albumin, you might want to give them albumin replacement. If it's infective, you might just sort of treat that. If it's very, very symptomatic and the patient is short of breath and really struggling to breathe and their oxygen saturations are going down, you'll want to do a pleural drainage. So that will typically just be through sort of a large bore cannula sort of thing. It's not very common that you use a chest drain properly for that. If it was an empyema and it was very infective and you're worried about sort of sepsis and whatever else, a chest drain would be appropriate. But just for your run-of-the-mill pleural effusions, just sort of small bore needles, large bore needles, apologies, would be absolutely appropriate. So also in more for your palliative care block, you might find that patients have recurrent effusions over and over again, and this is much more with sort of cancer, mesothelioma, and other things like that. And you would do what's known as pleurodesis, which is where you apply the sort of talc powder sort of stuff in between the into the pleural space, and this causes it to sort of scar up and close over. So it basically stops fluid from accumulating in there. So there are multiple ways you can do this. You can do sort of chemical method, or you can do a surgical method as well. You know, just be aware of that if you've got sort of a palliative question come up, and you know, this is the sort of thing that this is one of the options that you have for management. Finally, just a bit about asbestosis. I'm not going to go into too much detail about this. I don't think it's particularly important, and I think it's not very likely to come up in any great detail in finals. And I think that's the most important bit about this lecture, is just to teach you the only things that are likely to come up. So just the definition of it and sort of what causes it. So it's the long-term inflammation caused by asbestosis inhalation and sort of the fibers causing sort of scarring around the pleura. So you'll get sort of quite a vague picture. So it'll be shortness of breath, cough, wheezing, things like that. Sort of anything that might indicate sort of respiratory distress, respiratory difficulty. If they've got sort of an occupational history of sort of dock working or building or some sorts of mining as well, this might be the cause. It tends to have a very long lag period as well, so it could be at least 10 years, but often it can be up to 45 years. Sometimes it's been recognized. So, you know, it'll obviously be much more common in sort of older populations, simply because it has to take such a long time for it to present. So investigations, generally what you'll do is you'll go for a chest x-ray. So you'll find pleural thickening, which is you'll see sort of whitening, sort of very thick whitening around the chest wall. And you might also find pleural plaques, which I'll show you in the next slide. You can also do CT chest as well, which will also show in much better detail, much greater sort of sensitivity and specificity, the same signs on a chest x-ray. And you can also do pulmonary function tests. And this is number one, sort of to give you a good indication of sort of how the patient is managing. Unfortunately, it doesn't really give a very strong sort of a pattern. It's very dependent on sort of patient to patient. You can sort of get a restrictive pattern, but you can also get an obstructive pattern as well. I think it's also sort of appropriate to mention that the sort of people who tend to get asbestosis, they tend to also smoke as well. They tend to have other sort of very strong exposures. So that tends not to be a very useful test beyond sort of benchmarking how fit your patient is for other interventions. So we've got pleural thickening here. It tends to be a lot sort of more subtle than this, but you'll basically find that anywhere along the chest wall, you'll find that it's sort of a stronger white along there. And yeah, just keep an eye out for that. You might also find sort of pleural effusions alongside this as well, but apart from that, it tends to be just sort of this sign and this sign only for pleural thickening. And you can also get pleural plaques as well. So this is, as I've been described, as like sort of stuck leaves to the pleura. So you'll find that over repeat chest x-rays from different angles, you'll find these plaques that are just stuck to the pleura in exactly the same place. And they can cause sort of other sort of signs as well. So you might also find sort of pleural effusions and consolidations around that. So the complications as well, or just worth mentioning as well, is that asbestosis can sort of lead on to mesothelioma, and unfortunately there's not really a whole lot that you can do about it. You can also find sort of interstitial lung disease as well, so you can get through restrictive disease as well, and this is very much more just for the respiratory consultants and the specialists. So management, there's very little management you can sort of give out to improve the patient's well-being. Basically, one of the most important things you can do though is to reduce further harm. So if you counsel the patient to stop smoking, that will be of a great benefit. So I think is the stat that if you've got if you've got asbestosis and you smoke, you're 10 times as likely to develop lung cancer. Whereas if you only have asbestosis and you don't smoke, you're 5 times more likely than baseline. So basically, if you can get them to stop smoking, they're twice as they're half as likely to get lung cancer in the future. The other sort of things are more just for general interstitial lung disease. So you'll find sort of oxygen therapy helps, pulmonary rehab, sort of maintaining the lung function that they already have, lung transplant as well. And just sort of being aware of anything that might progress onto mesothelioma. It is worth pointing out that mesothelioma, though, only about 20% of the patients have asbestosis prior to diagnosis. So it's not really, it's unfortunately just a very horrible disease that there's not really a whole lot that can be done except for try to avoid exposure in the first place. So I think that's really the most important aspects of sort of lung cancer, pleural effusions and asbestosis. I hope this has been clear for you, and I would just say, thank you very much for listening. Thank you for turning up. I know it's very difficult to turn up for excess lectures, and I think the fact that you're here tonight means that you always stand a better chance than most of, doing really well come sort of June, July, whenever your finals are. So just before I sort of wrap up, has anyone got any questions? I'll take that as a no. So just as a little bit of advice, just to wrap things up, people tell you different things about where the best place is to go for sort of resources for finals. My recommendation would be Scott's Notes. So this is a doctor now, he graduated about 8 years ago, and he's basically put together about 4 different handbooks of essential finals knowledge. it's all free. He's made a website for it, and it's basically what got me through finals. And it's very concise. It's very detailed as well, and it tells you, it's detailed in the sense that it has like literally, if you want to go for top decile, things like that, if you know his stuff inside out, I think you're going to do really, really well. And my final bit of advice is that CBLs and CCTs are the only sort of piece of material that the medical school can guarantee that you've been taught properly. So this stuff will come up. It will cover at least sort of 80 to 90% of what will come up in finals. So I would know your sort of NICE guidance and your BMJ best practice for the core cases that come up there. That would be sort of definitely, if you learn that stuff inside out, you're going to do great come finals. So I think really that's all I've got to say. Thank you very much for listening. I do appreciate that you guys have stuck around long enough to sort of listen to my presentation. And just is that everything, Asha? Is that everything wrapped up?
Thank you. So yeah, please, I've sent the link for the SurveyMonkey, so please fill that in so there's feedback, and then you can get the slides as well. Also, I mean, did you do the recording?
I think, yeah, I think you did the recording. It came, yeah.
Okay, that's fine. Yeah, and the recording.